Okay. Hello, this is Karen Sales with the Dup15q Alliance. I am getting ready to, or we are starting the webinar we have scheduled today with Dr. Mark Corkins. He's going to be talking to us about GI issues and Dup15q syndrome. And we're very excited for this to get started. One thing I'm going to say is that currently everyone is muted. Um, we won't be able to hear any of the attendees. If you have a question, please feel free to type it in. And the last 15 minutes or so, we will leave for questions, and I'll kind of be going through those and asking those of Dr. Corkins. So without further ado, I'm going to go ahead and hand this over. And thank you so much for talking with us today.
Oh, it's my pleasure. I enjoy teaching. That's why I'm an academic institution. So, very quickly, I'm Dr. Mark Corkins. I am a pediatric gastroenterologist hepatologist, although I have a specific interest in nutrition. I'm a certified nutrition support physician. On the screen there, that's what the CNSC is. It's Certified Nutrition Support Clinician. And also, obviously, I'm working at a center that has duplication 15q. And I was previously at Indiana University where I was involved with the Sarkine Autism Treatment Center. So have a lot of experience working with children with autistic disorders, and I think it's important for everyone who works with these kids to have some understanding of the basic GI physiology involved in it, and also an understanding of how autistic kids can have GI issues and the different things that are involved with that. So let's get going here. There we go. All right, disclosures quickly. I am on a data monitoring safety board for a Nestle study. I have in the past been on the Nestle Precursors Bureau, although now that it's September, that's over a year old, so I actually could have taken that off. And this is a picture of the hospital where I'm at, Lobato Children's Hospital in Memphis. I'm at the University of Tennessee Health Science Center. This is the best little children's hospital you've never heard of. Beautiful building that opened in December 2010. The GI patients are all on the 12th floor, so we can see Arkansas, which is only 4 miles from this hospital. So 3 basic tasks. When you talk about the GI tract and how the GI tract works, it has 3 basic tasks. It's going to digest food, break it down into its component parts so we can use it. Absorption, once it's digested and broken down, you got to absorb it and get it into the GI tract. And the other part is motility. We got to move it along, you know. It's got to get from the top to the bottom and move along and let the parts do its parts. So let's talk a little bit. Let's start with digestion. Now, so basically, digestion is taking in what's needed and breaking it down to the basic nutrition parts. And the 3, what we call macronutrients in areas are fat. Fat is where it's at. By the way, that's where all the flavors are on the aromatic esters and everything. Fat tastes good. That's why we like it so much. Protein, you know, and that's the building blocks of most tissues. And then carbohydrates, which are basically the sugars and different forms of those. And then there's a lot of other things that are nutrients, vitamins, minerals, and fiber, and all sorts of different things that are involved in providing the basic nutrition. So there are really no studies that have shown any basic difficulties with digestion of any of the basic nutrients in autistic disorders. The majority of problems in autistic kids is problems with intake. Really, it's got to get in before it can be digested, and that's usually the main problem. Now, in human beings, appetite is driven by 3 different factors. Glucose is one of the driving factors. You have to have blood sugar. That's the main currency that our body runs on. It's glucose. That's like the fuel for our bodies. Number 2 is volume. Okay, when your stomach is empty, you should feel hunger. And if it's empty, it's growling and it's telling you, I'm hungry, I need something in there. When your stomach is full, you get this sense that I'm full and I don't need any more, you know, after Thanksgiving dinner, that kind of thing. And then mental. Now, human beings are interesting because we're the one species that if it tastes good, we'll still eat it, even if we don't have any real need for it. You know, it's like, again, Thanksgiving, when you're totally full, but then dessert comes up and you don't want to insult grandma if she's fixed your favorite pie, and so you have the piece anyway. So all three of these components are data, and it goes in the brain where it's processed, and that processing, that integration where it's processed in the brain creates our appetite, or if you want to think about our hunger, is those three different factors. So multiple studies have documented intake issues in children with duplication 15q. There don't seem to be any glucose issues as far as driving appetite. One of them, though, may be volume and volume issues, and I'm going to talk about that later, all right? And then there are the mental issues, and that's an important component of this, and you can't get around that. And those are functionally defined feeding problems. And some of them food refuse. They don't get enough calories from that. They have a food selectivity by type. They eat only a narrow range of nutritionally inappropriate foods. They like certain foods. You know, I've had a child that only ate white foods, you know, vanilla ice cream and popcorn and chicken. If it was white, they would eat it. They liked white foods, and it was a sensory issue. And a lot of the things with autism in general have to do with sensory and processing, and so it's a sensory issue. And then there's food selectivity by texture, and they don't eat developmentally appropriate food textures. Now, me and you, we hate bland, you know, food that's smooth, but sometimes they get stuck in that mode and they don't like a higher texture. And texture is also a sensory issue. And so literally, sometimes the selectivity has to do with texture. So again, so this food refusal, often this is a problem with the central processing and the integration and how that's all put together. And you can look and you can do all sorts of evaluations, and you know, any biologic issue it says that yeah, you know their lining is normal, and you know that those kind of issues don't show up as a problem. And what's interesting too is their programming says their intake weight is fine. Now, this is an important concept. We all have in our hypothalamus a programming that helps control our weight. And again, that's part of that integration of all those inputs. In adults, we have three states of metabolism. We have anabolic, building and growing, which, you know, it's usually bad for us. Catabolic, and that's we're losing and all that. But we have static in adults, and we're supposed to keep our weight within a certain range, and it's pretty stable for most of us over time. But like at Thanksgiving or Christmas time, if you eat more than you should, you know, then you feel like you've eaten too much, and actually the next day you kind of don't even feel hungry because your body's saying, hey, gosh, you're over that. Of course, that program also, if you start to diet and you lose a pound or two, it starts screaming at you, what are you doing? I'm starving to death, I'm dying. And we all know that. We all have you know, seen that. Now, in children are programmed to grow, and they should be growing, and that programming should be ratcheting up and increasing appetite to help drive growth, because we need those calories for growth. And sometimes something that happens with children with some programming issues in their central nervous system is their programming, it's almost like it's already in adult mode. It's in that static mode, and it says, yeah, your intake, your weight is fine, when actually they should be ratcheting up to grow, and they should be having an increasing intake, but they aren't doing it. And so when the kids get in that kind of an issue and they're stopping right at the point which keeps them steady, that's not appropriate, because for children to grow, they're programmed to grow genetically. They're going to be unhealthy because they are not supposed to be static. And then you start thinking about interventions, you know, and sometimes that requires medication. Sometimes it's simple supplements. Sometimes it requires a feeding tube, and you have to intervene. That's a last resort, but sometimes you're stuck, and sometimes you have to do that because they aren't going to be healthy. Children, since they're programmed to go, if their weight is even staying the same, they're actually robbing from their tissues and those kind of things to keep their body functions going. So again, catabolic or anabolic. Catabolic, we see that, like I said, that's cancer patients. That's tearing down tissues to keep things going. Anabolic is building tissues. Now everybody hears about anabolic steroids and they think that's a bad thing, but children are supposed to be anabolic, not with medications. They're supposed to be growing and developing in new tissues. Again, children are programmed for growth. To be healthy, a child needs to be anabolic. Some of the most metabolically active systems in our body, heart beating, breathing, the immune system, all need for us to be anabolic. And if you're not anabolic, you start robbing from things. And again, you rob from the immune system. And those kids literally, everything that comes along, they'll get it, and they'll have it for longer periods of time. Some other feeding problems that we see in kids with neurologic issues, and one of those is the feeding problems and some of the GI diseases. Now, the most obvious one is gastroesophageal reflux. Gastroesophageal reflux is one of the most prominent things that you see in kids that have feeding problems. It's one of the most often associated things with food refusal. Kids who have reflux have more feeding problems and have more likely to have food refusal and difficulty swallowing and all those things. So that's an important correlate, and it is an issue in children with feeding problems. Again, these children have the sensory issues, and so they do selections and color and taste. And some of the kids that we see in clinic will have a very limited and a very skewed diet. They have plenty of calories, but they're nutritionally imbalanced. If all you eat is protein, you need some fats. Fats are important for their brain development, and so you can be malnourished and still have plenty of calories, unfortunately. Again, sensory very much as well. They prefer the smooth to coarse. Again, it's more sensory input, lower to higher. Also, what's interesting is some of the children will have a very, very selective intake, and they'll actually have the selectivity, even though they'll tolerate higher textures, they'll have a selectivity by the type of texture. Some kids prefer crunchy versus chewy. They like things that crunch and have a crunchy texture, and then the things that are chewy they don't like so much. And so if it's a chewy texture, they'll refuse it, or they'll put it in, they'll chew, and then spit it out, as opposed to the crunchy textures. So again, texture is an important thing driving it. So let's talk a little bit about absorption. All right, so we talked a little about digestion, breaking things down. So once it's broken down, you have to absorb it. Well, again, there are no studies that have demonstrated any difficulty with any kind of the transporters in the GI tract. It doesn't appear to be no absorption issues at all. Now, there's a lot of old literature about inflammation and malabsorption, that autistic kids have a type of inflammatory bowel disease that's unique to them. There's a lot of stuff about casein and gluten and celiac disease, and to be honest with you, the studies haven't borne that out. They haven't supported that. Parents will ask me about scoping the kids and looking for these diseases, and it just hasn't been something that we've seen. In fact, there's studies that say that blinded studies that look at gluten intake and the behaviors of the children, and the one study that was actually blinded, where the parent didn't know if they were getting it or not, showed no difference at all. Some of the studies where it's open and the parents know, well, there's a bias, and so because of that, you may get a little bit of some skewed results. So the last area about digestion is motility. Motivation, moving things from the top to the bottom. I tell our residents, you can put a steak and a piece of cheesecake, or you can put a McDonald's hamburger and French fries in there, and they still come out as poop. All right, they start out the top, they go through the digestive process, the absorption, they come out as poop. And that's what motility does. It sweeps things through, moves them through. What goes in must come out. Now, some people use the term peristalsis. That's another description. And the GI tract actually has muscle layers, more than one. And the idea, again, is to provide that movement from the top to the bottom. So the purpose of motility is, again, these organized contractions to move nutrients along the GI tract from the top. What's interesting is it also has a function of digestion as well, in that it's like a mixer. This motility mixes the food with the digestive juices, kind of like a washing machine. You mix the water and the detergent with the clothes to kind of work on the getting them clean. Well, in this case, they're mixing the digestive fluids in the food and churning it around a little bit to help start the food digesting. And then there's also something called housekeeping function. It's to keep the bowel cleaned out. You move things through. You do eventually create waste. Well, you don't want the waste sitting in there. And so the idea of motility is to move it through, get it out, and keep the GI tract, the housekeeping. Now, motility is very, very important. So we have this intrinsic enteric nervous system. In the bowel itself, it has its own nervous system. I was actually a fellow when we did the second small bowel transplant in the United States at the University of Nebraska, which is where I did my fellowship. And we were very worried about transplanting small bowel because, well, it's not going to be connected to the main nervous system. And now everybody knew about this nervous system net in the GI tract itself. Well, it turns out it has its baseline rate of motility all by itself. Even if you transplant the bowel, it'll have its own enteric nervous system. There's almost as many nerves in the gut as there is in the spinal cord, and there's this nervous net that surrounds and is in the muscle layers and helps drive the gut. What's interesting is, so that is one of the big motility regulators. But another thing that regulates the motility in the GI tract is the foods themselves, which makes sense. We know this, even though we may not realize we know this. So foods themselves, carbohydrates tend to empty the fastest, the sugars, they tend to go through the fastest. Proteins are in the middle, and the fats are the slowest. Probably everybody's eating a big piece of pizza or a greasy cheeseburger, and it just sits in your stomach because the fats empty the slowest. So now this explains sometimes, though, why when you change the diet, you see differences in their stool output and stuff. If you put them on a gluten casein-free diet, well, the stools change and all that. Well, you alter the diet and you alter the motility. You have more of this or less of that, you alter the diet. Yes, you're going to change the motility by doing that, and so you're going to alter output and those kind of things. Another motility regulator is hormonal. The best example, of course, is thyroid. If you're a hypothyroid, you tend to get constipated and backed up. To be honest with you, I'm told that some of the menstrual hormones have an effect on GI tract motility, and things change with your menstrual cycles. Again, I am a guy, I'm told that's true, haven't experienced it. I will take the word of the woman I live with that it does. Central nervous system regulation. The central nervous system, now I said it has its enteric nervous system and it has a baseline rate of motility, but the central nervous system, if it's connected, also changes and regulates things. And so it can modify the basal rate. It can slow you up or speed you down. We all know this. Hey, if you got to give a big speech in front of a big crowd, we get those butterflies, and everybody knows about butterflies and how, and some people when they get nervous, they have to head for the toilet. This is a central nervous system input into the GI tract. It slows things up or it speeds them down. It has an effect, and that's that central nervous system input into our GI tract motility. All right, so let's talk about some of these specific issues that we see in the GI tract in kids, because now we have a little bit of some working knowledge. We know about digestion, absorption, and motility. Well, 60% of kids, let's talk about constipation, 60% of kids with 15q duplication, and this is a retrospective chart review, are reported to have constipation. Now, again, this is not perfect data. This is people remembering or looking at the chart. So this is retrospective. This is a very weak way to look at research data or try to get data. It relies on memory. It relies on the clinician to write it down. It's indicative, but it's not necessarily what we think of as gold standard data. Now, slow motility leads to constipation. Now, why is that? Slow motility means it poops in there longer. Well, the colon's main job is to absorb water. Now, let me give you some crude numbers. In an adult, with every meal, we dump in about a liter of fluid. Between saliva, stomach juice, liver juice, pancreas juice is about a liter of fluid. And that mixes with the food and digests the nutrients and all that out of it. If at the end of our small intestine we dump that out, we get dry pretty fast. So the colon's job is to absorb water. Now, Now, the colon doesn't have a shutoff switch or a sensor. So as long as this poop stays in there, the body's going to continue to take water out of it. So slow motility will lead to constipation. All right. All right. Dietary intake. Again, we've talked about motility and the effect on diet. Dietary intake also leads to constipation. You know, you change your diet, you change your food intake, you're going to have more constipation with certain foods because they slow motility. And so certain dietary intake, if your diet is skewed, you will tend to have constipation. One of the important factors also is stool retention. Now, bluntly, stooling sometimes is not that pleasant. It's a bodily function, but especially if you have a tendency to be a little constipated, it's a little uncomfortable. And it's messy, and it takes time out of your day. You have to, you know, take the time away from whatever you like to do or you're doing to go poop. And so we see a lot of children, and not necessarily all autistic kids even, who have stool withholding. Stool withholding, if you hold it in your colon, the longer it's there, the more water gets taken out of it. And it's a leading cause of constipation. You can actually hold on to it. If you want to make yourself constipated, just hold on to it. And you'll end up constipated because more water will get taken out of it. So if you want to try that, I don't recommend it, but you can. So constipation therapies, all right. Well, number one, obviously the ideal thing would be to alter the diet. For instance, more fruits and vegetables, increase your fiber intake. That would absolutely help constipation. Fiber will absorb some of the water, keep it in the diet. They tend to produce softer stools. Now, of course, we're talking here about kids with 15q, duplication, and may have texture issues and dietary intake that's selective. So that's sometimes a little, you know, it's easy for me to say it as a doctor and look at the parents straight-faced and expect them to do that when it actually may not be all that possible for them. That's the ideal, but it may not be possible. The other thing is we tend to use stool softeners. Now, we do not like to use laxatives, all right? We use stool softeners. These are osmotic agents. What they do is they get into the stool, they just keep water in the stool. They're different than a laxative. The trouble is the manufacturers use laxative and stool softener interchangeably. Medically, we think of them very differently because stool softeners just keep the stool soft by keeping water in them. Again, they tend to be osmotic. We tend to use stool softeners. The one most people use is Miralax. There's also mineral oil, which is oily and slimy, the kids don't tend to take. Some people use a very low dose of milk of magnesium. There's something called lactulose, which is a non-digestible sugar. Occasionally, in some kids who have a lot of issues and may have some motility issues, we'll use some very low dose stimulant laxative, and we try to use it infrequently and at low dose. The idea is to stimulate the bowel for motility to help them have a stool. Again, very limited use because the bowel will downregulate the receptors. You'll get dependent on a stimulant laxative if you're on it chronically at a high dose. Diarrhea, the opposite, and we also see this as well. This is higher motility. Again, may be diet related. I told you the carbohydrates empty the fastest. These are the kids who are drinking a gallon of juice a day, and that will end up causing them to have diarrhea because, again, they have high sugars, high motility. Occasionally we'll see kids who have a very good diet, but they have high motility. Usually we end up doing diagnostic studies to ensure that there's no other cause for this. Therapy for this, the first thing, obviously, if they're having a gallon of juice a day, is to alter their diet, to put some things in to slow things down. Maybe increase their fat intake if you can. Again, easier said than done. It's easier for me as a doctor to, say, hey, yeah, all you're gonna need to do is really change your diet. Take a diet history. It's like, oh man, that diet's really skewed. Just fix it. Yeah. Well, I have fathered 4 children, and I can tell you for a fact that not as easy as it sounds for me to say that. What about medications? There are some medications. They may slow motility. We're very judicious in our use of those. On rare occasions, we'll use an antispasm agent. Rarely an anti-motility agent, and only if we absolutely need to. Sometimes we have to. So let's talk a little more about reflux disease. And you know what's interesting is we talk about all these different categories. You know, gastroesophageal reflexes, gastric contents coming into the esophagus or the swallowing tube. Everybody has some reflux. We all know it is because, you know, we all have some. Unless you've had a surgery to tighten the valve, I've never seen anybody who doesn't have some. And there are certain foods, again, probably they alter motility, that will sit in your stomach and make you more likely to have it. Higher fat content and those kind of things. Everybody has some. Reflux disease is when something happens. There's some sort of disease or complication because of the reflux, or more reflux than is normal. Then we talk about regurgitation and vomiting. And these are things that are not necessarily reflux. You can regurgitate things or you can vomit things, and it's not always reflux. All right, so reflux. Again, this is a prospective kind of a study looking at kids with 15q duplication. And the actual number they came up with, 56.7% of children with 15q duplication have some reflux. Now, and what's interesting is the diagnosis of reflux in infants, they've studied it, cannot be made on the basis of symptoms or cluster symptoms. In other words, you can't make the diagnosis by what you hear or what you see. Unfortunately, some kids vomit and it may not be reflux, it may be something else. There is no standard kind of pattern that is diagnostic of reflux. Now, let's talk about etiologies of reflux. Now, as a GI doctor, we talk about primary and secondary reflux. All right. Now, primary reflux is your classic reflux, the type you think of when most people think about reflux. This has to do with the valve. Now, it's not actually a flap. People talk about the flap, and there actually isn't a flap. It's a sphincter. It's a circular muscle valve that opens or closes. So it's not a flap. So that concept is totally wrong. It's a circle, and in GI tract, we talk about sphincters. We love that word. It's kind of a cool word to say. Kind of rolls off your tongue. Get a little plosive syllable there. Sphincter. And also another cause of primary reflux is impaired esophageal clearance. And the esophagus doesn't strip things along like it should. Again, it's probably dysmodal. So again, normal reflux. This is primary is normal reflux. It may be pathologic if it causes problems. It may be reflux disease, but it's the standard type. It's the primary type. Everybody has some. Certain foods will increase it, and overeating will increase it. You know, it's like I'm thinking about the holidays, even though we're in the middle of the summer here. But you know, those holiday times when you have a little bit more than you should, you're more likely to have a little reflux. So let's talk about secondary reflux. Now, so this is secondary to something else if you want to think of it that way. If you have increased pressure in your abdomen for some reason, you have delayed gastric emptying, and that's probably one of the more important ones, or you have some mechanical problem, impediment to things moving through a passage through your GI tract. The symptoms will look exactly the same. It'll look the same symptoms, but the treatments are completely, totally, 100% different secondary for primary reflux. So let's talk about neurologic influences. Now, a lot of our data, of course, is from normal children, all right? But reflux, primary, secondary, whatever, the rates of reflux are higher in children with any kind of neurologic difficulty. And the reflux rate is 75% in kids with neurologic difficulties. What's interesting is they have a very high rate of poor stomach motility or delayed gastric emptying. And basically, in theory, you would call that vomiting because the stomach doesn't empty, the food sits there and sits there and sits there. It's got to go somewhere. Well, what's the shortest distance? Well, the shortest distance is up and out. These are also the kids that turn around and have the very high rates of dysphagia as well. They have trouble swallowing because the swallow is also neurologically mediated. At the bottom here of this slide, of course, one of the important things is to realize, do they have primary reflux or secondary reflux? Well, the problem is, we'd love things in the world to be black and white and one or the other, but what's interesting is kids can have primary, they can have secondary, but it's not mutually exclusive. You can also have both. You can have primary reflux and you have valve that doesn't work right, or you can have the valve doesn't work right and you can have poor emptying, or you can have poor emptying. So you can have A, you can have B, and you can have A and B. And so, that makes it very tough, and it's why a good gastroenterologist is your friend. At least I think so. Now, reflux therapy. What's our first line? Well, most of the time, our first line is acid suppression. You knock the acid down. There's an axiom known as Jackson's axiom in the GI tract. No acid, no injury, because that's the main thing that causes injury in the swallowing tube. So we knock the acid level down, and that's also a good volume, good amount of the volume of what's in the stomach. And again, if there's less volume there, less to come up. Motility-wise, or if you have primary reflux, less volume, less to come up. So acid suppression is usually the first line. Now, I get asked a lot about the surgical approach. What about, let's just fix this problem. Let's just do this, let's take the surgeon, let's tighten that valve, fundoplication. The fundus is the upper part of the stomach. You take it and wrap it around the lower part of the esophagus, and you create a tighter passage out of the esophagus into the stomach, and create a nipple valve. Well, the trouble is, great, if you have primary reflux, that's okay, except there's lots of complications with the surgery. Wrap too tight, wrap too loose, the wrap slips, and then what if you have secondary reflux and you have motility and the stomach doesn't empty well? Well, by wrapping the part of the stomach around the esophagus, you made it smaller. Well, it doesn't empty well already, and so the stuff sits there, then it can't empty, and then what happens is they tend to get retching and bloating and discomfort because their motility's off, and then you made it even smaller, and it blows up in your face, as I like to say. So the surgical approach, we are very, very careful about thinking about a surgical approach. So let's talk about delayed gastric emptying. Again, this is a motility, which is, again, extremely important. It's got to go through. If stuff sits in your stomach, you'll end up with vomiting or secondary reflux. But that's not an absolute. And some people, if they have poor emptying, their valve's working pretty good. Their valve's working overtime. It's working great. But if you don't empty, guess what happens? The food sets in your stomach. What's one of the drivers of appetite? I told you I was going to get back to this. Is volume, right? Well, what if you eat a meal and your stomach doesn't empty and the food sits there? Sits there and sits there and sits there. What's going to happen to your appetite? Are you going to be hungry if you have a full stomach? Nope, not at all. And so this is sometimes some of the kids who won't eat. Again, they may not vomit. They may not have the reflux if that valve's working good and working well, but then they won't eat. They refuse to eat. They'll eat a few bites and tell you they're full, or refuse to eat anymore. So delayed emptying is an important factor to think about in kids with autism and neurologic issues of any kind. Well, what's the therapy? Well, again, alter diet. Carbohydrates should empty faster. They may be better. Proteins in between. Fats are the slowest. But fats are a great source of calories. And we need fats in childhood because it's part of the brain tissue. But again, altering diet again. And if they have a selectivity, it may not be that easy. So again, sometimes we end up on medical therapies, medicines to help speed up the stomach and speed up the emptying from the stomach. I've already told you about fundoplication. Do the surgery, you get gas bloat. Or some kids, if the motility's good, but you make it smaller, they'll get something dumping where you put food in and it dumps out right away. That's also bad because dumping also causes all sorts of issues because the blood sugar goes sky high, then drops like a rock. So that's not a good idea either. Intake issues. So we're back again with intake issues. Talking about this in our kind of tour to symptoms and diseases, there are no real appetite stimulants available or being studied for that matter. Because of the obesity epidemic in the U.S., there's lots and lots of drugs looking at how to decrease or turn off appetite or change appetite. But there's not any real studies on, hey, where's a stimulant? What medicines can we use to stimulate appetite and stimulate kids to eat? There are some drugs that have appetite increase as a side effect, and some of those are used. But again, that's some GI doctors use that. Some of us who take care of kids in these areas will use them, but it's in a way almost like a side effect. If the kids are malnourished, they may require feeding help. If they're malnourished, to be healthy, you need to intervene. And I literally try to take a stepwise approach, and we only go as far as we need to go. But on the other hand, if they're malnourished, we need to go as high as we need to go to start getting the kids to gain and grow. Of course, we try to do behavioral interventions. Literally, from the very beginning, you insist on a variety of foods in the diet. Literally, early on, make sure that don't let them limit themselves. Insist that there be some intake and a wide variety of intake. What's interesting is these studies that say that even a normal child requires an average of 8 exposures to accept a food. So, children, what the studies tell us, are neophobes. They actually hate change. They don't like change. And when you expose them to a new food or a new taste, every child actually turns their nose up at it. So the average is 8 exposures. All right, so the first time you see something, it's like, what is this? This is new. I don't like it. Yuck, take it away. It's poison. I'm going to die. And so the second time they see it, well, I've seen it before. I didn't die from it, but I still don't like it. It's new. I've never seen something like this before. Yuck. And so basically, the average is 8. Now, chocolate cake, okay, maybe it takes 1. Maybe it doesn't take any for chocolate cake to be accepted, right? But something like broccoli, it may take 12 exposures. But literally, even a normal child will take 12 exposures. So one of the things you have to realize is that you need a slow, gradual introduction of new foods. Sometimes it's just a matter of take a taste. All I want is a taste. All right, good, a taste. And then go on and let them have something they like. And then the next day, take a taste again. Okay, because it's exposures. It's not volume, it's exposures. So take a taste again. And you literally get it to where, okay, this is not a poison, it's not going to kill me. And actually, after a while, it's kind of like, well, you know, that doesn't taste that bad. Actually, I may actually like that taste. But again, it's exposures, 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 exposures. So do not abandon ship. I see all sorts of kids who come to clinic and they say, you know, the parents say, well, I tried it and they didn't like it. Did you try it again? No, people didn't like it. Well, literally, what the studies tell us, you have to be persistent, you know. It takes a lot of exposures and a gradual, slow introduction. With the kids with autism, a lot of times you can actually get them to take a lot of different things if you have very reasonable, very gradual exposures that really doesn't push them too hard, but get through their neophobia, if you want to think of it that way. All right, so that was a quick overview of the GI tract, and I did that on purpose because last time when I did this at the meeting, had a ton of questions. And so I wanted to leave plenty of time for questions.
All right, thank you. Well, so far there's one question, and so I'm going to go ahead and ask that.
Okay.
Is it possible
Sure.
that any seizure drugs can cause kids to feel hungrier? This person says that her daughter was 36 pounds in January of 2014. Started Banzel in April of 2014 and then is now 50 pounds as of last week and a huge change in appetite.
Well, again, there are some drugs that have the side effect of increasing appetite. For instance, prednisone, which we use for asthmatics or for more inflammatory conditions, increases appetite. Some of the seizure meds decrease appetite, some may increase appetite. I've also seen kids who are having seizure activity sometimes below the threshold where you recognized it, and when they got on anti-seizure medications, their seizures were under control, and then they were trying to catch up from what they'd been missing. So that's a mixed answer. Sometimes it may be the drug itself, or sometimes it may be that now their seizures are under control, and they actually are trying to catch up. So it depends on what their weight was prior and where their growth was before, whether or not they're trying to catch up, or whether it may be an effect of the drug itself.
Okay. Our next question is, what meds do you use for motility?
Good question. All right, so there are 2 medications that are on the market for motility. One is low-dose erythromycin. Now you're thinking, I've heard that term before. Now, erythromycin is an antibiotic, and it has been around since the 1940s. But nobody hardly uses it because, quote unquote, it's hard on the stomach. About 9 years ago now, one of the companies that had the right said, gosh, this drug's a great antibiotic, but nobody uses it because it's quote unquote hard on their stomach. What they did was they looked and found out it stimulated the stomach motility as a side effect per se. And so a little bit of it, a low dose of erythromycin works great as a pro-motility agent. So a lot of GI docs use erythromycin as a pro-motility agent now. Some people are like, well, aren't you breeding antibiotic resistance? Yeah, per se, except that nobody uses it as an antibiotic in the big sense because it's hard on the stomach. So that one is a lot of times our first line agent in pediatrics. The other medication is Reglan or metoclopramide. And this is the one that has some central nervous system effects on the neural pathways. A lot of side effects. There's a black box warning on this one that it can cause something called tardive dyskinesia. And so you have to watch for these involuntary movements. If you want to think of it in one-way tics. And if you see those, you have to stop the drug if it develops with the drug. Otherwise, they become permanent. So it's got a lot of side effects and a lot of issues with it, although it does work and it does stimulate the GI tract motility. You just have to be aware of the side effects and watch for them. There are some other drugs out there. There are several other drugs in the U.S. They're not available widely. They're not on the market per se, but they're available compassionate use. And some of the GI doctors have them available. You have to do a special application to the FDA. You have to do a protocol and follow the kids on the protocol for some of these special agents. Propulsed or cisapride is one of them, and another one is domperidone. And again, these are special agents. You usually have to go to a specialist in nutrition or motility to get those agents.
Okay. As a quick follow-up, the same person just asked, she said that my son takes 3 bisacodyl daily and still does not have a daily bowel movement. Is this bad to be on long term?
Well, if the bisacodyl is not doing it, that means at some point you need to think about some sort of intervention or some sort of change in your therapy. You need to be on something to help stimulate the output. Again, sometimes that does require a little bit of a once-a-day dose of something stimulant. Sometimes it requires a bigger dose of something that's a bigger, stronger softener. For instance, Miralax probably is the best softener around, and everybody's scared of it, but basically it's been used in thousands and thousands of children, and it's gotten some bad press, but none of that's actually been borne out scientifically.
Okay. Our next question is, my daughter gets constipated and at times her breath smells like poop. I feel like it's because she's so backed up. Is this possible?
Well, if it can't go forward, where's it going to go? The GI tract is a closed system. In a way, some people have pointed out the GI tract is completely outside our body. Goes in the mouth, comes out the anus, but actually is never open anywhere throughout the entire GI tract. So, if you plug the drain in your shower, the water collects around your ankles. So, It's got to go somewhere. Matter's neither created nor destroyed. So if the gas is in there, it's got to go somewhere.
Okay. My 4-year-old seems to be very irregular. Some days he seems to be constipated, but generally his stool is on the loose side. Would you recommend something like probiotics to help regulate him more? They have tried a small amount of kefir daily, but it seems to cause diarrhea. What brand of probiotics would you recommend?
There are a lot of probiotics, and there's not been some great studies in the autistic kids. There are some little bit of work with Align, which is a Bifidobacterium infatus. There's been some work with Culturel, which is a Lactobacillus rhamnosus or Lactobacillus GG. They changed the name of it. Actually, the one thing that will buffer out your stools is fiber. Now, hear me out. Fiber, we all think of fiber as being for constipation because it absorbs some water and keeps some water in the stool. But what they've added to the infant diarrhea formulas is fiber, because if you're having diarrhea, the fiber will absorb some of the water in that stool and add some bulk and body to the stool. Fiber is actually a buffer. It helps constipation and diarrhea. Fiber helps keep us in the middle. So if your stools vary a little bit up and down, the ideal thing actually is to get your fiber content up. and that will help both constipation and diarrhea.
Okay. And then that answers a question that came up as well with how to firm up stool, and sometimes it's loose, sometimes it's firmer. Okay,
Yep.
so then the next
Of course,
question.
it varies with diet, and part of the problem is, if we ate the same thing in the same amounts at the exact same times every day, we could adjust things, but we don't, and none of us do. And so even normal people, their stools will vary a little bit day to day based on our diet.
Mhm.
And so that makes it a little fun as a gastroenterologist, because it's kind of like, if you want your stools to be exactly the same, you eat exactly the same thing, exactly the same amounts, exactly the same time every day.
Okay. And then as kind of as a follow-up to that, when you mentioned fiber, a question, soluble or insoluble fiber?
The ideal probably is a little bit of both.
Okay.
A little bit of both.
Okay.
They both have their benefits and their value.
Okay. And then we have a question. It says, my child has an increased rate of motility, and by that they mean 4+ times a day. There's
Yep. Yep.
no issues with a balanced diet. He does seem to suffer from intense gas pain. They treat him with
Right.
acids and gas chewables. Is there a trend among our kids and or better treatments?
Well, the problem, the duplication 15 kids are one extreme or the other, and it's probably got to do with regulation. They tend to either have constipation or diarrhea,
Mhm.
and again, it's probably regulation of the motility. The ones that have the diarrhea, again, in theory, you could alter the diet. You actually would go slightly higher protein and fat and slightly less carbohydrates. And if you can skew the diet a little bit, that may help you. There's also some medications you can do. And if you have to, sometimes you can do a little bit of some medication to help with the decrease in motility and some of the spasms in the GI tract. That cramping from the motility sometimes is what causes that discomfort and the cramping. A lot of times these kids are seen by a GI doctor. Sometimes they'll do a little evaluation to make sure there's nothing else going on as well.
Okay. Um, Then we have this person's son has allergies to dairy, tree nuts, and eggs. His weight stays the same. He loves what he can have. Doctors tell them to give him bacon because of the fat and some other unhealthy foods. Would you recommend that? I feel bad giving him unhealthy foods. What are your thoughts? He does withhold every day, and they are getting ready to start Miralax.
Yeah. Well, and that's not a surprise. Yeah, a lot of the kids, unfortunately, you need a little Miralax. I wish I could tell you that, oh no, yeah, if you eat a good diet, but some of these kids sensory, even if their diet still aren't that firm or anything, they will withhold. Um, the American Academy of Nutrition and Dietetics, the American Dietetic Association is the old name, but they changed their name. Their mantra is that all foods fit. Um, and so, in a way, our diets are supposed to be balanced. Um, there's a place for sugar, there's a place for fat, there's a place for protein. We eat all three. I mentioned all three because we need all three. Now, yeah, bacon's greasy, and there's nitrosamines, and there's salt and all that. But on the other hand, there is some value, the protein there, and the fat currently for a child, actually, first few years of life, you actually are supposed to have a high-fat diet. So I don't think of any food as evil or bad. Now, again, some of it's supposed to be in moderate amounts or small amounts, and so I would urge them not to think of it as like there are certain foods that are bad foods. Now, again, I don't give my child, I have 4 children, we don't give them chips on a regular basis, but here and there they're kind of a treat. It's like I jokingly talk about chocolate cake, but I can't remember actually the last time I actually had a piece of chocolate cake. It may have been my birthday in February because my favorite's German chocolate, but it may have been that long since I've had chocolate cake. But here and there, it's okay. Sorry, I got on my soapbox there, but there's no such thing. Yeah, sorry. So that I don't like for people to think of anything as wicked or evil or bad. Now, there are foods, and per se, we talk about nutrient density. That's one of the important concepts: is how much nutrients are you getting in return for what you're taking in. And so, some foods have very high calories and very little nutrient value. Some kids have a lot of nutrition, even though they may have a lot of calories, they're worth the nutrition that comes with them. And so we think about the nutrient trade-off, nutrient value for calories. So if they're trying to get their child to gain weight, and the deficit is calories, and the first thing you have to get into a child to get him to gain is the calories, then is it bad? Is it the real final line is, are they gaining with that, or do they need some sort of an intervention? Because if they're not gaining weight with it, they need some sort of an intervention, and they need to go the next step. And so, again, it's hard for me. This sounds like a child that needs some very close assessment and somebody to follow the child, to work with a dietitian, and really kind of coordinate a plan and a long-term goal of intake for this child.
Okay. And then we've got two questions that kind of have to do with withholding, I think. The first one was, I was told, this person was told that her daughter's rectum was stretched out from storing and that surgery may be in the future. How will this affect her long term? And then the next question was on thoughts on Botox to prevent withholding.
Well, you do Botox, you paralyze the sphincter, you prevent withholding, but then you create soiling. If they can't control their anus, then they're going to soil on you. That tends to be a socially, the kids aren't that fond of soiling, and the parents aren't that fond of soiling, and teachers and classmates and folks around you aren't that fond of soiling. The rectum stretching, there's enough elasticity in children that usually, if you can get the stools on a regular basis, with enough time, now it may take a year or so, but if you can have regular stool output without retention, eventually, usually the colon will go back to its normal shape and size. The problem is, if it's chronically retaining stool, that's a signal that you need to get the stool to come out on a more regular basis. And if there is enough dysmotility, sometimes the problem is you can't get to that point.
Okay. All right. And then we have a question. If kids lack water intake, let's see. If a lack of water intake causes constipation, this person says, I currently feed my child water with a syringe to make sure he gets enough.
Well, now, again, this is another soapbox issue for me, all right? Our body has the ability to take water from absolutely any liquid we put into it. And in fact, some of the solids that have some water content, we can pull the water out of that. Now, if you don't have enough water intake, yes, you will be constipated. But water, on the other hand, is not a therapy for constipation. It's actually been studied. You can look it up. Rosemary Young did a study trying to use water as a therapy for constipation. I told you the colon's main job, its actually main job is to absorb water. If you take and give more water, though, to the GI tract and the poop stays in there, the water will still get taken out of it. When they tried to use water as a therapy for constipation, what happens is the stool output didn't go up. What happened is they peed more. The body absorbed the water, the extra water, and they actually just produced more urine. So it still has to come out and still has to go through. So water is actually an ineffective therapy for constipation. You have to have a minimum amount, yes, or you will be constipated. But on the other hand, more water isn't fixing constipation. If, for instance, there's dysmotility, you can put more water in there, and all that's going to happen is it's going to go in the colon, it's going to sit there, and it's going to get absorbed, and you're going to end up peeing it more. And that's actually been studied and shown. I wish it worked. It, in a way, seems logical, but actually, in point of fact, the way the colon works, it's not a therapy.
That's interesting.
Oh, I know. It's kind of like, oh, rats.
Right.
But if you understand how the colon, that's the reason I went through how the colon works. That's why. So if you have dysmotility, you can pour water in all you want, and then you'll be changing lots and lots of wet diapers or changing, peeing all the time. But literally, the colon's job is to absorb that. That's what it does. It does a great job of it.
Okay. And then the last question that we have right now is, are multivitamins like Flintstones vitamins worth giving if she doesn't even chew well? She says that her daughter's diet is very poor.
All right. Well, so Here's again, and you guys are hitting all my soapbox. Multivitamins are completely unnecessary if you eat the diet that we're supposed to eat. You have a balanced diet with dairy, fruits, vegetables, proteins in the right amounts and the right, you know, right proportions. We don't need vitamins. You know, people live for centuries without vitamins. The trouble is, if the diet is skewed, the vitamins can help make up some of the deficits, especially if the diet is very, very skewed. Now, the problem, of course, is that some of those vitamin and minerals that are necessary, I will tell you this, can't be put in a gummy. The gummies have the water-soluble vitamins, but the vitamins and minerals that won't go into a water-soluble form can't be made into a gummy. So those are the chewable, the chalky ones. So those are the better vitamins, unfortunately. And so you're stuck with a chewable. If the diet is very skewed, the vitamins are designed to be very safe. There's a very high threshold before you get any kind of poisoning or toxicity. So a daily vitamin actually makes some sense if the diet is very out of whack.
Okay. Well, that is actually all the questions that we have, and it is right up there with 4 o'clock or an hour in. So how about we go ahead and we'll thank you, Dr. Corkins, for taking time out to talk to us and give us all this wonderful information. And we will be making this recording available for everyone else to review when they have time. So thank you so very, very much. We really appreciate it.
My delight. Thank you very much for inviting me.
Thank you. Okay.